All right. Well, hello and welcome to the ASCO Daily News Podcast. I'm your host, Dr. Monty Pal. I'm a medical oncologist, professor and vice chair of academic affairs at the City of Hope Comprehensive Cancer Center in Los Angeles. Today, we're highlighting key abstracts that were presented at the 2025 ASCO Quality Care Symposium. I'm delighted to be joined today by the chair of this year's meeting, Dr. Fumiko Chino. Dr. Chino is an associate professor in radiation oncology at MD Anderson Cancer Center with a research focus on access, affordability, and equity. She's also a consultant editor of JCO Oncology Practice and the host of the Put Into Practice podcast. I've got to listen to that. Dr. Chino, welcome, and thanks so much for being on the podcast today.
I'm overjoyed to be here, and absolutely, you should take a listen.
Definitely. And FYI for listeners, our full disclosures are all available in the transcript of this episode, so do have a look if you're inclined. Now, we've really seen some fantastic advances in health services and quality and supportive care, digital health, and beyond. There's some great abstracts that were presented at this year's meeting. I've actually picked a couple that I'm particularly interested in and that I believe you share my interest in as well. So the first is an abstract actually from my friends at SWOG. So this was a terrific abstract from Joe Unger and Michael LeBlanc and Don Hirschman. And this, I think, really hits on a very, very key issue now, which is the benefit of federally funded trials. Do you mind just kind of spelling out some of the observations from what I think is a really brilliant piece of work?
Absolutely. And I think Dr. Unger's work is really important for our current funding environment. I think that this research is really essential to do to show really the role of federal sponsorship in the design and conduct of clinical trials. Because what they did was really look at a landscape analysis over the last 20 years, looking at funding, and were able to show quite clearly that federal funding really matters for advancing the science in cancer care. So what they showed was that the federal funding was more commonly essential for early stage clinical trials, so those phase 1, phase 2 trials that really help advance the science. And that federal funding was really essential for multimodality drug combinations with drug and surgery, combinations with drug and radiation. Those trials were much more likely to be federal funded. And then the last thing is that they showed that the patients that are, I think, the largest at risk for gaps in care, who really need the advancements in science that keep U.S. healthcare amazing and wonderful and world leading. So the kids, the pediatric patients, the patients with rare cancers, and the patients actually that could benefit from de-escalation or right sizing of treatment, they were also all more likely to have federal funding. So I think this research that was presented really shows that if, unfortunately, current status of restricted federal funding continues, that we are going to lose out in terms of the next generation of cancer cures, cancer de-escalations, and the type of combination treatments that make advancements in science.
Indeed. I always point to Joe Unger's paper, and I think it's in JAMA Oncology, right, that showed life years gained from NCI trials. It's such an important piece of work. I think this is a really nice complement to that, isn't it? To show the specific areas that otherwise would be, am I right in saying, kind of largely untouched?
I think you're right in that what we know from what industry will sponsor versus what the federal government will sponsor, that the federal government really helps make up the gap to really make those advancements that save lives, that lead to more birthdays, that advance our knowledge and our capacity for providing more cures and more successful futures for our patients. I always like pointing to the de-escalation research, which is, and this is not to dig pharma, but no pharmaceutical company is going to run a trial that says you can give less of their drug, right? It just doesn't make sense for the business end of the science. And so thinking about how to right-size treatments, how to do more with less, that really is the purview of the federal government.
Absolutely. Absolutely. I'm going to shift gears here and bring up another abstract that I found to be quite intriguing. And this relates to reimbursement of expenses, et cetera, for clinical trials. This is an abstract from Courtney Williams and team. It brings to mind the importance, I think, of recognizing the hardships that patients take on by clinical trials. But I also would love for you to comment on that sort of fine line between reimbursement for expenses and then, sort of undue enticement. It's a it's a challenging balance there. But give me your reflections on this abstract.
Absolutely. You're speaking about Dr. Williams' abstract 93 from the Alabama group. And Alabama actually has this incredible group of health services researchers, are doing really important work in this space. What this trial shows is that, it's a small pilot study. It's 30-something patients that received some support primarily for their travel and additional expenses related to their clinical trial participation for breast cancer. It showed that the money helps. And I think what we all know is that it's expensive to participate in clinical trials. It requires additional visits. It often requires some significant travel burden for our patients. And I do not feel that money reimbursement for clinical trial expenses is an inducement. Nobody participates in a clinical trial to get the money for their gas, right? We know that our patients are making some pretty significant sacrifices in order to participate in clinical trials. And what this type of program does is just actually reimburse them for their outlayings of funds. And I loved this trial because the patients were actually given $1,000 a month for the first 4 months of their trial participation. And what the study showed is that the patients were using it for things like travel-related food, for things like transportation, caregiver expenses, or even some other out-of-pocket medical expenses like cost sharing or prescriptions. And that they said that overall, the reimbursement really made a difference in terms of their capacity for staying on the clinical trial, because we know our clinical trials really aren't able to enroll the full diversity of patients that often have a disease, and that the patients that are at biggest risk for a healthcare disparity or a gap in care are also the least likely to enroll in clinical trials. Programs like this are an essential part of showing how financial toxicity can be overcome with pretty straightforward assistance to patients to help reimburse them for the things they're already taking out of their pocket, for parking costs, for that $10 soup that they buy at the cancer center, for those additional expenses that we are unfortunately putting on them.
Very well said. And, I started to dabble in clinical trials looking at CAR T-cell therapies for kidney cancer. And I have to tell you, it's just insane the amount of costs that a patient would have to take on to comply with stipulations for some of these novel therapies. We require that they stay within 30 minutes of the facility for 28 days. And unless we're compensating for some of that, how can one afford a hotel stay that's that long? It's unprecedented. And it would certainly provide a huge barrier to many patients who would otherwise enroll. Really well said. I also wanted to bring up another financially driven topic, and treating renal cell. Again, I would say the vast majority, 90% plus of my patients in clinic, are on oral drug therapies. And I can't tell you how often a patient will show up in my practice and say, "Doc, I've got 15 days out of this 30-day prescription left. What do I do with it?" Or some come with pill bottles from a deceased loved one. And it's so frustrating to say, take it to the pharmacy and they'll just get rid of it for you. But it sounds like there's an abstract from Dr. Mackler, abstract 102, that seems to address this topic quite well. Am I right?
Absolutely. This presentation, I was the most excited about seeing, because this group, which helps run a cancer drug repository, theirs is called YesRx, presented their data from the last approximately 2 years of running this repository, and they were able to show incredible benefit for their patients in Michigan. And it's a really straightforward program. It's run by pharmacists. It has support from the legislation in Michigan. And what they were able to show is that they repurposed medications that would otherwise have been discarded. They delivered them directly to the oncologist, which then actually dispersed them to the patients. They helped 1,000 patients in less than 2 years. They saved them millions of dollars, over $15 million presented in the abstract. And it's just a win-win-win, because I know that patients actually, and sometimes patient caregivers, they feel very sad to have spent a lot of money out of pocket for their medication. And then if they have a dose reduction, or obviously, if the surviving spouse then has to get rid of their medications, just dispose of them, it's very disheartening. And this is a way of kind of reclaiming power for patients. So they were able to accept donations from all over the state of Michigan, and then also help over 1,000 patients. And so it is a phenomenal program.
Just wild. When I came across the dollar amounts, right, that they were saving, it seems like a place that, we just have to look as cancer centers, right, and really take this on. Just brilliant. on that same theme of cost savings and so forth, I think there's been a lot of focus on what recent policies have done in the context of us having access to therapies and so forth. And one of the topics that's come up is the Inflation Reduction Act and how changes pertaining to the IRA have really played a role in one's ability to take on some of these expensive prescriptions. And I believe John Lynn and colleagues tackled that issue in Abstract 97. Could you comment on that, Fumiko?
Absolutely. Dr. Lynn is one of my colleagues here at MD Anderson, so I know him very well. And he's been doing really phenomenal work over the last several years with looking at a drug affordability and access. And what his analysis shows is that for patients after the Inflation Reduction Act's cap on out-of-pocket expenses, that it really did show that out-of-pocket expenses decreased. So what the Inflation Reduction Act did is that it eliminated the 5% coinsurance and it placed this $2,000 cap on out-of-pocket expenses. And what that led to for these patients that weren't able to have the low-income subsidy is that they were lower costs and that there was a lower rate of drug abandonment, meaning that the prescription wasn't refilled. There was also a lower rate of unfilled prescriptions as well. And I think that it shows that health policy really can improve access to care. I think the flip side of the fact that the IRA, this policy really did seem to help people is that what his research showed is that actually, even with the benefits of this cap, is that actually it's still really high in terms of the rate of people who aren't able to fill their prescriptions or that completely abandon them over time. And that unfortunately, even with this change, that over half of people without the low income subsidy were potentially not getting the full benefit of their medications because they weren't able to afford them. And so I think it really kind of highlights that we still need to do more work about making drugs affordable.
Indeed, indeed. And I mean, in a setting like this, I think it's important to recognize that $2,000 is a lot. It's a big chunk of change, right, for a lot of families in the U.S. What do you think of the prospect of decreasing that cap? Is that something that from a policy standpoint you would be supportive of?
Well, so something that is a real option for our patients on Medicare is there's something called the Medicare Prescription Payment Plan. And what it allows you to do is actually prorate the $2,000 over the whole year. And so instead of having to pay $2,000 as soon as you fill your prescription, because you are going to have, if you have an expensive medication, it's essentially you have to pay the $2,000 in January, right? It allows you to prorate it. So essentially $170 a month. And that comes to you as like a regular bill. And I think that as rolled out as part of the IRA is a really lovely way of thinking about how do we make these payments more stable over time so it's not a huge hit sort of at the beginning of the year. And I think that alone actually can make a difference in terms of trying to help make sure that people can actually get their medications.
We're going to shift gears entirely. We've been talking a lot about the dollars and cents of things and talk about an abstract from Sophia Smith and colleagues. This is Abstract 550 at your meeting. And this hinged on a program of sorts to deal with post-traumatic stress disorder. And we don't often think about PTSD as in the vernacular for oncology patients, but indeed, it's something that they must face, especially in the context of long-term survivorship. Can you talk a little bit about Dr. Smith's abstract?
Absolutely. I love this work from Dr. Smith, who is at Duke. She worked with Dr. Applebaum, who was my old colleague at Memorial Sloan Kettering. And this group of researchers really is trying to figure out how to best support people into survivorship so that they can actually thrive. And their patient population for this work was actually people who received stem cell transplant. And they focused on people who had PTSD symptoms. And what they were able to show through this SMART design, which is essentially this serial multiple randomized trial. So everyone got randomized up front to either usual care or this app, so this digital app that actually helped coach people through cancer distress. And then for the people who were non-responders, they were then additionally randomized to either the app plus coaching or a therapist versus the cognitive behavioral therapy or CBT. And what they were able to show is that, number one, anyone who had the app seemed like they did better than who didn't start the path with the app. But then the additional help of either the therapist or the coach or the CBT made additional benefit over time. And so I think this shows a really nice stepped care, which is you can potentially have some right sizing of treatments cost saving if we sort of give everyone the app, which is, I think, overall pretty low cost. And that for the people who don't get the full benefit from the app, then you can think about these maybe more tailored approaches, the therapist, the coach, the CBT, but that some people will actually just respond to the app. And I think it allows us to, again, right size the care for our patients. And I think it's really innovative to think about how technology can help improve access to care in the setting of something like PTSD.
Brilliant summary. Brilliant summary. Gosh, it looks like such an exciting meeting this year. Congratulations on a terrific program for the ASCO Quality Care Symposium. I know you played a huge role in developing it. Thanks for sharing your insights on the ASCO Daily News Podcast.
Really appreciate you having me. ASCO Quality is my favorite meeting of the year. It's really a phenomenal meeting. And I'm just so excited for next year in Boston in 2026.
Awesome. And thanks to our listeners, too. You're going to find links to all the abstracts that we discussed today in the transcript of this episode. Finally, if you value the insights that you heard today on the ASCO Daily News Podcast, please rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.